Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Otsuka America Pharmaceutical, Inc.
Welcome to this Medscape education event called Bridging the Gap, case-based exploration of current and emerging therapies in IgA nephropathy. I'm Rich Lafayette. I'm a professor of medicine at Stanford University, and I'm very privileged to have our wonderful faculty with us today, and I'll let them introduce themselves.
I'm Miriam Chung. I'm an associate professor at IgAN School of Medicine at Mount Sinai in New York, and I'm very thankful to be here.
And hi, everybody. I'm Alessia Fornoni. I'm a professor of medicine at the University of Miami Miller School of Medicine in the division of nephrology.
And just as a starting point, we all know IgA nephropathy is a rare kidney disease with a prevalence here in the US of only about 2.5 per 100,000 adults. It is the most prevalent primary glomerular disease in the world and particularly prevalent in East Asian patients. The clinical presentation, however, is variable. A common presentation is for patients just to have borderline hypertension, mild swelling, or to be completely asymptomatic. We do have a classic presentation when patients present with gross hematuria, particularly in the face of an infection, such as a viral infection. And again, patients can have a great degree of heterogeneity in terms of their proteinuria, but it's only rarely a cause of nephrotic syndrome, such that when there is nephrotic syndrome, we think of other diseases. A real concern is that most patients in the United States have chronic kidney disease at the time of diagnosis. So we do believe patients are diagnosed late, and that leaves them at a very significant lifetime risk of end-stage kidney disease, where within 15 years, probably at least half of our patients will progress to end-stage kidney disease already. So it's a significant challenge. And now I'll introduce you to a patient, Ariana, who will talk about her experience in living with IgA nephropathy.
Hi, my name is Ariana. I was diagnosed with IgA nephropathy in September of 2022. So I actually had been spilling protein in my urine since 2011, but none of my doctors that I had been seeing were ever concerned about it. I had always had a high white blood cell count and all my blood work. I also had blood in my urine, but the doctors, again, didn't really seem too concerned. So I just kind of let it go for years and years and years. But in early 2022, I want to say around February or March, I started having lower back pain and I was kind of putting it off. Then, after a couple of weeks and it wasn't going away, I started having a lot of blood in my urine. And so that's what made me go to my primary care doctor. She was really willing to listen to me and order a bunch of tests. And so I went ahead and had a urinalysis done, blood work done, and it came back that my GFR was at 70 and I was spilling around 3 grams of protein in my urine per day. At that point, she went ahead and referred me to a nephrologist. In April, I was finally able to go see a nephrologist. He wasn't really too concerned with what was going on. He thought that I had a chronic UTI. Because I had been waiting to see him for a couple of months and dealing with insurance stuff, I was looking up my own symptoms online and I noticed that my symptoms aligned with IgA nephropathy. And so I was ready to hit the ground running. At my first meeting with this nephrologist, I came to him with all of this information, my previous labs, everything in a little binder. And I told him, I think what I'm dealing with might be this rare disease. And he laughed me off and said, there's no way you have that. It's a very rare condition, so there's no way. I think we just need to rule out the most common possibilities. And in your case, that would be a UTI. And also because you're diabetic, we need to make sure that we're putting you on metformin, even though my diabetes was controlled just with diet and exercise. So I agreed. I went ahead and got on 3 separate rounds of antibiotics. Was also taking metformin. Nothing was really improving. I felt like he wasn't listening to me and he wasn't trying to dive further into what was going on. I still had the same exact values in all of my labs, except my GFR was dropping every single time. It dropped from 70 to 34 under his care, and he never mentioned it to me one time. My family was so upset. So I went, got a second opinion. I called probably every clinic in Houston, and finally I was able to get seen by who is now my current nephrologist. He's a pediatric nephrologist. And at the very first visit, I went in, I told him what was going on. I told him all the symptoms that I had been experiencing, everything that I had gone through with the first nephrologist. And he was like, okay, I think you probably have some kind of glomerular disease. So I had the biopsy about a week after I saw him. And then when I got the results a couple of weeks later, it came back that I had IgA nephropathy, which is what I had suspected all along. I'm currently just on a blood pressure medication. It's working extremely well for me. I'm no longer spilling any protein in my urine. So I feel really lucky. It was caught in time that I didn't have to go on dialysis. I'm not facing transplant or kidney failure. But at the same time, I think I could have started treatment months sooner, but I didn't. And so that is something that weighs on me.
Yeah, so I think this is a all too common story, sort of partially explaining late presentations where patients can have minor symptoms that they often don't recognize, but even in this case, when they do recognize it, sometimes the medical community is slow in really understanding the seriousness of proteinuria, of even mild reductions in kidney function, and don't get to that diagnostic biopsy quickly. Thoughts, Miriam?
Yeah, well, thank you, Ariana, for sharing that story. I agree. And I think the importance of seeking second opinions, third opinions, and to see a specialist in this IgA, which is a rare disease. Um, Something to be said is the proteinuria is resolved, but the GFR is lower to 35 from 70, and it's on blood pressure is controlled. Assume probably with RAS blockade, but something to consider to sort of target at the same time is not only the chronic kidney disease management with the blood pressure control with RAS blockade, but also to target with medications that can target the immunologic disease. We now have agents that can target specifically the IgA production, the IgA, galactose deficient IgA1 production. So perhaps go at the same simultaneously consider targeting with immunomodulatory treatment as well.
Yeah, and Alicia?
You know, again, thanks, Ariana, for making the right self-diagnosis. I think that's impressive. Unfortunately, we see that often that the patients are ahead of us in making a diagnosis. And, I really wonder, we have seen this progression despite the regression of proteinuria. We've seen the GFR drop from 70 to 35. And just like Miriam mentioned, I wonder whether starting early is B cell modifying agent would have helped to slow this progression. I'm really wondering whether this is a case that also show how the persistent hematuria may be a marker of inflammatory ongoing disease that tend to progress irrespective of the degree of proteinuria, but definitely I would consider additional agents.
Yeah, and exactly to those points, I think we're in this era now where we have new guidelines. Again, they're draft right as we record this, but they'll become official soon. That really talks about a much more aggressive identification of patients who are felt to be at risk based on their entire presentation, in line with the international IgA risk score, and at very least to consider people at risk when they have more than 500 milligrams per day of proteinuria, and then to really consider all those aspects that may eventually lead to failure of that kidney. So not only to manage the generic responses to the IgA nephropathy-induced nephron loss that may already be there or arise through, again, lifestyle modification, blood pressure control, and really trying to reduce that glomerular hyperfiltration and other secondary processes, including cardiovascular risk reduction. So we will maximize our RAS inhibitors and more use SGLT2 inhibitors. And these days we have approved drugs to help that, including endothelin blockers such as sparsentan, which was approved at the time of these guidelines, and atrasentan, which was approved subsequently, but also to look at the disease itself, as you both mentioned, and think about managing those IgN specific drivers, including glomerular inflammation, including the deposition of immune complex. And at the time of the guidelines, we really had systemic or targeted release steroids, targeted release budesonide, and thinking about risk benefits of those approaches. Subsequently, we do have the approval of iptacopan as a complement blocker in geographic areas. Maybe other agents like mycophenolate, hydroxychloroquine may play a role, but there has not been evidence to support that globally. Tonsillectomy, perhaps in Japan, but not outside. So times are changing. We have more tools, but the important thing is to really realize that we have to be aggressive in our therapy. And I'll just turn it over to Miriam for some just initial thoughts about complement blockade in the form of iptacopan.
Right. So, iptacopan is a factor B inhibitor, which inhibits part of the alternative complement pathway, and this was published in the New England Journal of Medicine. And when they looked at the interim efficacy analysis of about 250 patients, uh, they saw a reduction in proteinuria at 9 months of about 38% compared to the placebo group. And the majority of these patients were on RAS blockades. I think over 99% were, and about they were also allowed to be on SGLT2 inhibitors as well. And the incidence, there was no increased incidence of infections between the iptacopan group versus the placebo group. And this was approved by FDA approved in August of 2024 based on this data.
Yeah, that's great summary and gives us more tools. And again, I think it'll be very instructive to hear from Thelma about her journey with IgA nephropathy today.
Hello, my name is Thelma Barber, and I am a patient living with IgA nephropathy nephrotic syndrome. Well, at the age of 12 years old, I suffered with a lot of swelling in my hands and in my feet. Unfortunately, I grew up in a underdeveloped area, and Medicaid was one of the sources of health insurances that my family had to use. When my mom finally did take me to a clinic, the doctor told my mom that I needed to lose weight, that the weight was pushing down on my limbs, causing them to swell. Now, mind you, as a 12-year-old, I'm sitting there like, wait. And it was very disheartening for me because I was a very active 12-year-old, excuse me. I used to run track. I was in a marching band, and to have those signs and symptoms was very frustrating. But if it was weight we were supposed to work on, the doctor never gave my mother any medical nutritional information like a dietitian or any diet for me to follow. So a decade later, I'm traveling along with IgA nephropathy being undiagnosed, but still with the swelling in my hands and feet. And I came down with flu-like symptoms. And I went to a doctor. They did a simple dipstick. Now, who knew after college that my commercial health insurance would help me change my zip code and my area code to seek out a professional in New York City? And that's what I did. And they found blood and protein in my urine. And of course, that's not supposed to be there. They ran tests for lupus, HIV, and everything came back negative. And the doctor said, I think you need to go see a nephrologist. And a kidney biopsy was done in 1993, which revealed that I had IgA nephropathy, nephrotic syndrome. Once I was diagnosed with that disease, it was very devastating for me because no one knew anything about it. how you got it, or what to do for it. Instead, at this time, I was just told to go home and take fish oil vitamins and call us when the kidney goes. And in 1998, as the disease progressed, I needed to go on dialysis. But I had three people who were willing to come and save my life, which was my husband, my sister, who was a twin, and my brother came to step up for me. So once I received that life saving transplant in 1999, I was able to get back to a regular life and a regular routine. However, once again, still no information, still no treatment, still nothing to help me with the IgA nephropathy. But at this point, I was just looked at as a patient post transplant. In 2008, I was blessed to get pregnant with my miracle twin boys who were born prematurely. But during that time, the doctors thought that I was exhibiting preeclampsia and thought that I should decrease my pregnancy by one because they thought it was going to be a very high risk pregnancy. However, it was the IgA nephropathy, nephrotic syndrome coming back. After I gave birth to my children, my nephrologist suggested that I multi-list in order to get a second kidney transplant, and that is what I did. From New York all the way to Florida, I relisted for a second kidney transplant and was blessed in 2011 with a second living donor transplant in Charlotte, North Carolina. At that time, my kidney, unfortunately, started to reject, and I had to go on many treatments in order to have that kidney preserved. Treatments included immunoglobulin infusions and a whole lot of other medication in order to keep that kidney. After the kidney rejection scare, which it really was a scare, I am doing great today. I'm thankful that my nephrologist put together a plan that is helping me live out my life, as well as a medical nutritional therapy that is working. Now, I can't say I'm running marathons because, of course, I have a whole host of other issues, but I'm grateful that I'm getting around pretty good. Can't run marathons, but I'm grateful for life.
Wow. Again, another very, very powerful presentation, unfortunately marked by um, sort of, we talk about late presentation, but sometimes it's more late understanding of the seriousness of the patient's symptoms and signs, and we just get too slow to intervene in these patients. And at the time she was diagnosed, there was probably interventions that were either too toxic or ineffective. Alicia, you have thoughts about this case so far?
This case is really the clear evidence that we need to intervene early. We need to intervene early. We need to intervene at early processes in the disease so that we can prevent that progressions that Brenda unfortunately had to live and experience with her disease. So that's really my take home message is early and maybe combination treatment. No, when you have a patient that get diagnosed when it's already active but still very progressive, it's really I really wonder of the all different pathogenetic mechanisms that we know about the disease, whether multi-targeted therapy would be appropriate.
Yeah, Miriam, other thoughts?
Yes, completely agree with you. The importance of intervening early, target both the immunologic IgA disease and the chronic kidney disease aspect. And this also shows how much advances we've made in IgA in the last few years. When Thelma was diagnosed in the early 1990s, none of these were available. And that's also the hopeful part of the future of IgA with advances coming out actually every year. So
Yeah, I agree entirely. And to that point, I think it's really nice that we have the new guidelines looking at new approaches with recently approved medications, but the future is quite bright, particularly in the effort to try to control immune complexes, control inflammation. I think we have new agents lining up, and I think we can sort of look at that we really do have a large group of B cell modulatory drugs to really stop immune complex, hopefully in turn to limit inflammation, that are APRIL inhibitors, APRIL BAFF inhibitors, or anti-CD38 agents. We have complement inhibitors. We already are taking through the Tracopan development, which is very exciting. Other agents are lining up to block factor B as well through different mechanisms. and we have our traditional C5 inhibitors. So it'd be great, Alicia, if you can just take us through a little data review about these B cell agents, and that would be really wonderful for our audience.
Sure. As you mentioned, it's great to see so many agents in this space, and both BAF and April are involved in B cell proliferation, and some agents target both. Some agents target only April, and the question has always been there: is one superior to the other, or is it better to do both? And I think the data clearly show that they're both effective, and so this is the case of SIB that target only April. And in this phase 3 trial and month 9, you can see that there was a 50.2% reduction of the UPCR in 24-hour compared to the baseline. So really, if we look at the placebo-adjusted treatment effect, is 51.2%, which is quite remarkable if you think that in this particular study, I think between 35 and 40% of the patient had SGLT2 inhibitor in their standard of care. No, so really quite remarkable effect on proteinuria. The full analysis of this ongoing trial is expected in 2026. We need to see the eGFR data, but if you look at the atacicept, we can, the phase 3 trial completed enrollment, and what we can see in the phase 2 study, the key finding was a reduction in UPCR of 31% in the combined doses, 75 and 150 versus 8% in placebo, resulting 25% reduction versus placebo. I want to comment that in the phase 2b atacicept, only 5% of the patients were on a SGLT2 inhibitor, while in the phase 3, actually up to 60% of the patients were. And if we look at the 36-week EGFR increase of 0.8 in combined in the two doses, I think having this stabilization slash slight improvement of the EGFR at 36 weeks is very promising, and really suggests that maybe we are entering an era where we may see EGFR improved irrespectively of proteinuria with some of these disease-modifying agents. And again, the study went into 96 weeks open label extension, and again, showing reduction of very significant reduction of hematuria in the three groups, in the three doses, sustained reduction in galactose-deficient IgA1, reduction of UPCR up to 52%, similar to what we have seen with the agent that target only April. And the preserved kidney function, as I said, with a slope of eGFR of -6, which is really expected in a healthy individual.
Yeah, that's great review. And Miriam, there's still rationale for a lot of excitement about complement inhibitors too. Can you walk us through additional study here?
Right. This is the ravulizumab study, which is a C5 complement inhibitor. This was the phase 2 study where patients were randomized to either get ravulizumab or placebo for about 26 weeks. And then from 26 weeks to 50 weeks, everybody received open label ravulizumab. And the data shows at 26 weeks, those ravulizumab group had a proteinuria reduction of from the baseline of about 42% versus 16.8% in the placebo group. And when we look at the annualized GFR slope, it was the reduction was much better in the ravulizumab graph versus placebo group at 26 weeks and at 50 weeks as well. The proteinuria reduction was sustained at week 50 as well in the ravulizumab group. And what's interesting is in the patients who were in the placebo group who crossed over to the ravulizumab group at 26 weeks, they also had a similar decrease in proteinuria reduction at week 50. So again, this highlights the reduction in proteinuria and sort of attenuated GFR loss in the ravulizumab group.
Yeah, so I agree. I think there's just tremendous room for enthusiasm for our patients. I think this is unprecedented times. We use that term a lot, but certainly we really do feel this is a golden age for IgA nephropathy. Many agents are in development, many agents already approved. So we really have this expanding toolbox. These agents target several distinct pathways. And again, as Alicia mentioned, combination therapy really could prevent disease progression altogether, and even potentially return some lost kidney function. That's still aspirational. However, I think it all starts with increased detection and screening because we need to find patients early, intervene effectively, individualize care for each of our patients. So we have to really look for subclinical kidney disease and figure out ways to work with primary care, general nephrology, glomerular disease specialists, patient care organizations, and really improve recognition. We all need education, patient colleagues all alike, and that will really move this field forward. I'd like to have a chance for final comments from our panel. Miriam, further thoughts?
I think this is an exciting time for studies in IgA nephropathy. So much advances are being made, and as Alicia mentioned, with this new the April and BAFF inhibitors, we see not just reduction in proteinuria, but GFR stabilization, which we have not seen in even 4 or 5 years ago. So I do think this is very exciting. I think it's very hopeful for patients with IgA now, and looking forward to it.
Beautiful. Alicia?
I share the excitement about being a nephrologist out there with outpatients running a glomerular disease center. It's so nice to have the opportunity to discuss options with patients and to have all this hope coming with the current medications and the great data we have seen, but also the upcoming ones. I do think that we may be capable in the future to say, hey, we have found a cure for a disease that never found a cure. And that would be amazing for us.
Yeah, I think that's wonderful. So again, early detection, aggressive control of patients' issues in IgA nephropathy, including controlling their CKD, controlling glomerular inflammation, reducing immune complexes, all when appropriate, and really looking for achieving GFR stability, which is often seen by really good protein control. So thank you everybody for participating in this activity. And there's tools and resources on the side of the page. So thank you, faculty. Thank you, participants. Thank you for our patients. And have a wonderful day.